Now we're up to the part where we kind of have to go back and revise osteoporosis. So the way the first aid CK book is designed, they already spoke about osteoporosis in endocrinology, which shouldn't feel too far-fetched because it makes sense given the fact that a lot of that does have to do with endocrine, especially with PTH, right? So if we come back to here, this has basically already been discussed, right? So we don't really need to talk about it anymore. But one of the key things here is this whole PTH thing. If you don't truly understand the activity of PTH, how PTH and vitamin D work together rather than against each other, and all the different enzymes and organs that are involved, like the liver and the kidney, then you want to make sure you revise that, get it all down pretty well. And then one of the things that a lot of people tend to often mistake is the renal failure aspect of things. So if we go back here, let me see if I can find it. Should be a table for, yeah, this one. Diagnosing parathyroid disease. So here, this table needs to make sense to you, and it should be something that you should be able to generally reproduce, because all you're really seeing here is calcium on the x-axis, PTH on the y-axis. Generally speaking, when somebody has primary hyperparathyroidism, they have a lot of PTH, and all that PTH successfully rips calcium off the bones, so you have a lot of calcium, right? So this is what you're seeing on the top right. High PTH, high calcium, boom. Primary hyperparathyroidism for whatever reason, one of these. Then there's primary hypoparathyroidism. So you see how both go together. Either both are going to be high or both are going to be low. Primary hypoparathyroidism, you don't make any PTH at all for whatever reason, most commonly surgical resection, because you have to get rid of your parathyroid for some kind of cancer. And then now you end up having lower calcium also, because PTH is pretty important for managing calcium levels. So these two are not that complex. Then you have the other two case scenarios here, where you have really high PTH, but calcium doesn't go up. Right, so this is secondary hyperparathyroidism. And so what's happening here is one of these two case scenarios, but the one I want to talk about is chronic kidney disease, right? So when you do questions about chronic kidney disease and you know that the patient has renal failure, you want to understand that if PTH is high, usually what we do is when we pick any answer choice where PTH is high, we also end up picking that we're going to have high calcium, right, and we're going to have low phosphate, right, because that's what PTH does. PTH throws away phosphate and increases calcium, like that. But this is assuming that the kidney is working. So you have to be very careful when you do a question and it's a patient with renal failure. In renal failure patients, there will be high PTH, but this won't happen. The PTH won't successfully have an effect on the kidney in changing calcium and phosphate levels. Right? So calcium would be low, phosphate would be high. It would be the other way around. Calcium would be low, phosphate would be high, because it's almost like there's no PTH at all, because it's not actually effectively able to do what it needs to do at the kidney. Right? So that's one of the tricky things that a lot of people tend to often mess up. And then when we did these endocrine videos and we did our endocrine sessions, we already talked about some of these questions which revolved around having too much milk, right? So there were questions where, this question specifically, milk alkali syndrome, and any question where someone who's too young, like newborn, not newborns, but young kids, like 10, 11, those ages, having too much milk every day. That was another topic we saw a lot of as we went through endocrine. So all of this was discussed in endocrine, including Paget disease of bone. This is also here. So you want to make sure you remember the Paget mnemonic of things, right? And then they have their own mnemonic here as well. And just the key differences. The key differences between these was really important, because most questions, although there are a lot of differences between them, most questions won't give you all the differences. So you'll be given minimum information, and then you'll have to figure out difference between all of them by yourself. So right here in MSK step 1, we can see osteoporosis. This is a failure of normal bone resorption due to defective osteoclast. So the main issue being defective osteoclast. You don't have osteoclasts who are supposed to go ahead and break bone. So then you end up getting thickened. Oh, sorry, this is osteopetrosis, excuse me. Right, defective osteoclast, where you can't break bones, so you end up getting thickened, dense bones that are prone to fracture. This is a very rare topic. It's also a very rare question that you would get, but they can give it to you and not tell you a lot of information, and then just give you an X-ray like this. And what you need to realize is this is really dense bone. This is extra white. It's not supposed to be that heavily white on this X-ray. Right? So then you start figuring out what must be going on. And most questions about osteopetrosis are about carbonic anhydrase 2 mutations, which is the answer you have to pick. And that's generally all there is for that. Osteoporosis is the more commonly topic and commonly tested topic, where you get vertebral compression fractures. You can get fractures like this, the Colles fracture, right, where the distal radius at the wrist breaks. And then they ask you very technical things sometimes, but the general the general theme here is the trabecular thinning. Right, trabecular thinning. So your bones don't have that good of a trabecular interconnection, and that's really something that'll mess people up. They tell you here that's diagnosed by bone mineral density measurement using a DEXA scan, and you need to have a t-score of less than -2.5. Then you know it's osteoporosis. You could also diagnose this if a person has been coming with fragility fractures, right? Fractures that you wouldn't normally get just because of something simple, but these people would get it. So that's the vertebral compression fractures and the Colles fractures, these things. When people get these weird fractures that wouldn't normally occur in anyone else with good bone, then you start thinking osteoporosis, and you have to give them bisphosphonates. And remember, bisphosphonates had a lot of side effects, right? So you have to take this with a lot of water and don't lay down after taking it, because it causes esophagitis. It also causes osteonecrosis of the jaw and messes up the jaw. So it's a very scary medication. And then there's the other guys, teriparatide, selective estrogen receptor modulators, which could be helpful in women who are over 65 or anyone who's postmenopausal and developing really bad osteoporosis, right? So that's generally all there was to those topics. And right here they have this table where they kind of give you the up and down arrows, the up and down arrows, and you can get stupid questions with these up and down arrows all day, where they can add extra things like osteoclast function or osteoblast function or renin formation, stuff like that. You know, they could just throw in anything else. But primarily, you want to get these arrows correct, and then look at the remaining extra thing they might add to your question, and use your best judgment and knowledge to figure out what that might be. All right. So that's basically it for those topics. Coming back here, then it continues on to this topic of a Morton neuroma. This is a pretty small topic. Neuropathic degeneration of nerves, most commonly between the third and fourth toes, that causes numbness, pain, and paresthesias, often associated with a clicking sensation when palpating the joint space, occurs in runners, and symptoms worsen when metatarsals are squeezed together. So, such as people who wear high-heeled shoes, right? So it squeezes all your toes together. Especially if they're those pointy shoes. Treatment is with padded shoe inserts, right? You just want to bring comfort. That's all it is. So this is a type of neuroma that can easily be confused with somebody having diabetic paresthesias, because if you have unmanaged or poorly managed diabetes, you could get numbness, pain, and paresthesias in the feet, right? Or pretty much anywhere, but most commonly in the feet of diabetic patients. So you have to be very careful with them and be understanding of what is actually happening. So the two populations are very different, right? Because you have the diabetic, and then here you have the runners, or people who wear high-heeled shoes and stuff. So you can definitely catch this in a question, even though they might try to throw things in there to confuse you. After that, they move on to gout, where we're all kind of pretty accustomed to the general idea of gout, but where students get messed up in gout questions is the treatment of gouts, right? Where I came up with a pretty simple thing, so we'll talk about it. Let's look at it from here. So recurrent attacks of acute monoarticular arthritis resulting from intra-articular deposition of urate crystals caused by disorders of urate metabolism. So this is like a little bit of biochem, right? Any issue that's causing urate metabolism problems can lead to gout. And one of the easiest ways to catch it is that it's monoarticular. So you're really just going to be one area that's having this painful arthritis, and it's going to be very acute. Right? So then you know it's gout. Risk factors include male genders, obesity, postmenopausal status in women, and binge drinking, which is one of the tricky things they throw into question. Someone who might have had a crazy night out to celebrate a promotion or something, and then the next morning, boom, right, this happens. Presents with excruciating joint pain of sudden onset, most commonly affects the first metatarsophalangeal joint, which is podagra, and the midfoot, knees, ankles, and wrists. The hips and shoulders are generally spared, which is going to help you figure out that it's not like one of the bone disorders, and it's not general arthritis or any of that stuff. They could throw in things into the question to make you think of like osteoarthritis or whatever, so you have to be very careful with that too, differentiating it. Joints are erythematous, swollen, and exquisitely tender. Tophi, which are urate crystal deposits in soft tissue, can be seen with chronic disease. Tophi can ulcerate and discharge a chalky white substance. Uric acid kidney stones are seen with chronic kidney disease. So basically, you shouldn't really touch this. Don't touch this. Let it be there. You know, it's gonna, when you start taking treatment and stuff, it'll eventually go away. What I don't know is why his nail looks so fucked up. That I don't get. You know, I don't know if he has some like nail fungus thing, or maybe this is a homeless person. Because the messed up nails are, especially this messed up nail, the big toe one, is kind of taking away from the real center of attention here, which is the tophaceous gout, a slowly enlarging nodule of the right second toe in a 55-year-old alcoholic hypertensive man who's taking hydrochlorothiazide. Right, so this is nice that they tell you this. So being an alcoholic patient with hypertension, he could possibly be someone who might also be homeless or often out on the streets and whatnot. And boom, you know, being an alcoholic, this is basically your body telling you to stop drinking. Diagnosis, just joint fluid aspiration. You just look at it. We did this in step 1 as well. You're going to see needle-shaped negatively birefringent crystals versus pseudo-gout, where you're going to see positively birefringent crystals, right? So there's a key difference between the two. We're going to see that. Lab tests and imaging, you can do serum uric acid, which is going to be very high, but patients may have normal levels depending on what caused the gout. X-rays may show punched-out erosions with overhanging cortical bone, a rat bite erosion, that are seen in advanced gout. Now, I've never really seen this actually, so let me go ahead and find a picture to put here. Gout, rat bite erosion. These radiologists are very clever with these silly little names. Yeah, I don't see it per se. I don't see the rat bite they're talking about, but this is a cute picture. They've got a little rat there too. Honestly, I would not really think of this as gout if I ever saw this, so it's good that we looked up this picture. That way we would know to think of gout if we ever have this presented to us. Let me see if I see anything else anywhere. Yeah, I mean, most of these are showing a pretty good erosion that's occurring. That's kind of what that is, right? This is erosion here. That bone is basically gone, right? It turned black like the background. So that's what they're calling a rat bite erosion, which honestly takes a lot of creativity to come up with that shit. But that's what radiologists are. They're very creative with their... This one's good too. Let me show you this one. Whoa. Oh, I didn't know you could do that. Paste. This is actually pretty nice, right? So here you can see the same thing. You make it smaller. Another person with gout, so they have this erosion right here that I could draw the same rat for, basically. Right, so that's the rat bite erosion they're talking about. Now, it's really important whenever you see these kinds of things in questions, not in questions, sorry, when you're studying and you see these kinds of things in your notes, that you look it up, because, you know, if you haven't seen it before, then you can rest assured it's going to be on your test. I don't see any other good pictures, so that's basically it. And it's going to show up on your test, and it's basically going to be all you're going to have to pick the correct answer off of. So, yeah, that's your... Now, of course, this never happens in this area. You know, in these areas, whatever bone is affected would never have this kind of erosion in just one area. You know, if you have rheumatoid arthritis, osteoarthritis, or any other chronic autoimmune systemic problem, then you would have erosions, but it will be on multiple areas and possibly bilaterally. These are the things you want to consider. This is just going to be monoarticular, just one area, right? So that's your rat bite erosion. Now treatment. This is the thing that has always confused people, because you get questions, you easily figure out it's gout, you're sure it's gout, it's very clear, it's obvious. And then they're like, what do you want to give this patient? And that has always been confusing for people, because they'll usually have all the answer choices there, everything. Alright, so let me see. Let's see how they talk about it in First Aid 2021. Oh my god, my arm hurts so much. I can't even raise my shoulder any higher than this. So here you have your gout drugs, right? You have your chronic gout drugs, which you would give for preventive reasons to people who tend to keep getting gout attacks. And then you have your acute gout drugs. Now, what's really interesting here, and this is what I use for my memorization purposes, is that to treat acute gout, you use medications that would theoretically be chronic medications, right? NSAIDs and glucocorticoids are not something you just take one tablet one day and then that's it, like Tylenol, right? NSAIDs and glucocorticoids are chronic medications. Most people take NSAIDs or glucocorticoids for a long time. So to treat acute gout, you use chronic medications. To treat chronic gout, you use medications that are never used. You don't really use these medications at all. Definitely not chronically, right? Allopurinol, pegloticase, febuxostat, probenecid. These are all medications that you don't tend to really ever use. Right? This is literally allopurinol you do use for many other things, but it's not a chronic medication. But then these three over here are literally just for gout, right? So you can see how your question is more than likely going to be someone with an acute gout attack, and they'll ask you what you should give them for treatment, and you should just pick the NSAID, glucocorticoid, or colchicine. Now, this question gets further difficult, which I'm pretty upset to see that even in First Aid 2021, they haven't really made it very clear. But you can't just use any NSAID. And there's no way you would know this unless you've had the experience or seen it in a practice question, or you learned it in your rotation or something, right? So there was an NBME question where they kind of put multiple NSAIDs as an answer choice, right? And you have to know which NSAID to give. Also for glucocorticoids, you can't use all or any glucocorticoid, right? They don't tell you specifically which medication to use. They don't write down the name of the exact medication that helps the most in clinical practice, right? So be very careful with that. You know, so NSAIDs you cannot give to patients with renal failure or peptic ulcer disease, which is something I've repeatedly been mentioning, so it sticks to you guys. So use colchicine or selective COX-2 inhibitors like celecoxib, right? And for glucocorticoids, you just use prednisone, not dexamethasone, right? So that's something that you have to keep in mind. Now, there was a question where they had multiple glucocorticoids and multiple NSAIDs as an answer choice. I don't know where I really put that question. Let's see. Did I make it a note? No. It's not up here, right? No. Okay. Well, let's take a look at this question. So this one has febuxostat as an answer choice, which is rarely actually an answer choice. So 33-year-old woman comes to a physician for a follow-up exam. She has a history of Crohn's disease, for which she takes methotrexate. Okay. She and her husband would like to start trying to have a child. Because of the teratogenicity of methotrexate, the physician switches the patient from methotrexate to a purine analog that inhibits lymphocyte proliferation by blocking nucleotide synthesis. A typical step 1 question where they're telling you the mechanism of action of a medication. Right? So which medication inhibits lymphocyte proliferation by blocking nucleotide synthesis? Toxicity of the newly prescribed purine analog would most likely increase if the patient was also being treated with which of the following medications. So now, first you have to figure out what the medication they're giving is. What are you going to switch methotrexate with to give this other medication? And then they try to give you a hint that medication, if you're taking that medication and another medication together, that's going to lead to increased toxicity. So what's actually happening? Before we even look at this explanation, actually we could look at it and then I'll go show you something else. So here the answer was febuxostat, right? They're asking toxicity of the newly prescribed purine analog, the medication whose mechanism they described, would most likely increase if the patient was also being treated with what else? So that medication and you're taking febuxostat together, that's going to be really bad because the medication they're taking is 6-mercaptopurine, which is based off of allopurinol. Febuxostat, a non-competitive xanthine oxidase inhibitor, increases the risk of toxicity from 6-mercaptopurine. Normally, xanthine oxidase metabolizes 6-mercaptopurine to inactive metabolites as well as to active compounds that account for its immunosuppressive properties. Inhibition of XO increases the rate at which 6-MP is converted to its active metabolites, increasing these compounds' serum levels and putting the patient at risk for toxicity. This has to be something that's extremely commonsensical and simple for you all, so you want to make sure you get where it comes from. If we go back and look at, I believe it was discussed around the urea cycle topic. There's a really nice diagram for it. No, actually really early here. There, I remember now. Okay, so right here you're seeing azathioprine metabolism, not allopurinol, azathioprine. Right? So azathioprine becomes 6-mercaptopurine, which is a purine analog medication that you can use to stop lymphocyte proliferation. You could treat many kinds of things with this. Now, 6-mercaptopurine has to become active metabolites through the activity of HGPRT, hypoxanthine guanine, PRT, whatever that stood for, the whole thing right here, right, where you can get Lesch-Nyhan syndrome, HGPRT deficiency. So HGPRT actually converts this to the active metabolite, which is then going to go do its job. Then there's xanthine oxidase and another enzyme, TPMT, but that's less active. So the xanthine oxidase is the one that turns it into inactive metabolites. That way you don't end up getting overdosed. If you're taking allopurinol or taking febuxostat, both of them are xanthine oxidase inhibitors, you're going to slow down the inactivation of 6-mercaptopurine. This gets tested pretty highly on step 1, and this is still something that can get tested on CK as well. Because you could have a patient who might be taking 6-mercaptopurine. They might not even tell you very well that the patient is taking 6-mercaptopurine, but rather just tell you they're taking some medication to treat some other case scenario. You would have to know that the medication must be 6-mercaptopurine. And at that point, if they're taking allopurinol, what you would have to do is one of two things. Either lower the dose of 6-mercaptopurine, because they're going to have high amounts of it anyway since they're not inactivating it that quickly, or switch them to 6-thioguanine, which actually doesn't need xanthine oxidase. 6-thioguanine is metabolized by the other guy only, TPMT. Okay, so these are some of the things. Now, if you don't remember these medications, then you go back to your I think it was right here. Yeah. Right, so you have all your medications, cyclosporin, tacrolimus, and all that stuff. And let me see, where's the 6-mercaptopurine? Azathioprine, there it is, yeah. Okay. So you have your azathioprine, which is an anti-metabolite precursor of 6-mercaptopurine. It inhibits lymphocyte proliferation. You could use it for rheumatoid arthritis like our patient was in that question. Actually, that patient had Crohn's disease and many other autoimmune conditions. It's a very commonly used medication, which is why it's a very commonly tested medication. Right? So be very careful with this combination of these weird medications that someone could be on, plus the concept of gout, which is where we are right now. So they tell you for acute attacks, high-dose NSAIDs like indomethacin are first line. Right, first line. So you want to make sure you get this stuff perfectly down. This is the answer you're going to pick. In CK, they've written it for you. You pick indomethacin. And only go with celecoxib if they can't take anything else, but indomethacin is the answer to pick. So there was a question where they had multiple NSAIDs. Indomethacin was one of the answer choices, and the patient had no contraindications to NSAIDs at all. But then that question became very difficult to understand because there were multiple NSAID answer choices. So what do you do now? So you pick indomethacin, because when you look this up, gout treatment, you would find research that shows that indomethacin had the highest success in treating acute gout. Not all NSAIDs work the same, okay? Colchicine may also be used, but it's inferior to NSAIDs, and both were actually answer choices on that question as well. Colchicine was also an answer choice. Steroids are used when NSAIDs are ineffective or contraindicated, such as in patients with renal disease or peptic ulcer disease, as we said. Maintenance therapy, allopurinol for overproducers, those with contraindications to probenecid treatment, tophi, renal stones, chronic kidney disease, and refractory cases, probenecid for undersecretors. Right? So this is secretion related. Someone who has oversecretion of urea, right, and urate crystals, you would go ahead and do allopurinol. Otherwise, if they have undersecretion but they're getting gout, you use probenecid. This is going to be given to you. They'll tell you how much urate crystals they're making in the question, and then you have to use your best judgment to figure out what's actually best for that patient. Allopurinol can actually decrease the incidence of acute urate nephropathy as well, which is good. You want to avoid nephropathy at any cost possible. Weight loss and avoidance of triggers like alcohol and whatnot will prevent recurring attacks in many patients. Avoid alcohol entirely if possible. So there's many causes of hyperuricemia. One of the most commonly tested are the cell turnover. People who might have had some kind of chemotherapy, they're at risk of getting gout. And if you know someone who's had a history of gout and then they're about to get chemotherapy where you're going to end up killing a lot of cells in their body, you want to go ahead and treat them with preventive gout drugs before you start the chemotherapy. Right? That's the key thing there. So tumor lysis syndrome, as we saw in step 1, and we've seen here when we did our hem-onc, is something that can lead to gout. Otherwise, some of these things don't really often show up that much. Lesch-Nyhan syndrome was a major step 1 topic. Lead poisoning and salicylate overdose are not exactly that high yield topic for a gout question. Starvation this could be someone who's trying to diet because they have a mental illness of how they look, or someone who's maybe an athlete and they're trying to get put onto a team or something and they need to lose weight, right? So this can occur, this can lead to gout. This is also very common in the Muslim community where when Ramadan comes around and we all fast, I remember one of my uncles, he actually can't really fast because he gets gout every time he tries fasting, right? So that's really problematic, and it just sucks. It sucks, and even taking preventive medications won't really help that much because the starvation would be a whole month thing, right? So if he's fasting for an entire month, the preventive medications won't stop him from getting gout. It'll end up happening at some point anyway, and that really sucks. Here they tell you colchicine. Colchicine is something that inhibits neutrophil chemotaxis and is most effective when used early during a gout flare. However, it can cause diarrhea and bone marrow suppression with neutropenia. Right? So it's just a little fact of things to revise from back here, right? From step 1 pharmacology. All right. So let me see. I just have to check what I've written here because I might have gotten confused with myself. Right. It is, oh yeah, okay. Indomethacin, I just need to write that in here. Right. For the NSAID you use indomethacin, and for the glucocorticoid you use prednisone, not dexamethasone. Right. There's a lot of questions on this thing. It's really dumb. It's really dumb. So you want to make sure that you have this topic down. Let me put it in right now before I forget. Okay. That indomethacin is the best NSAID for gout, and prednisone is the glucocorticoid for gout, and then you have colchicine, which you might not want to give to people if they have any GI or neuromyopathic problems to begin with. Right? So this is a tiny little farm topic that they can definitely toss at you. Here they have a table for gout versus pseudo-gout. There's a major difference in the crystal birefringence aspect, but there's a couple other differences here too. So if we actually go back and look at it, because it's easier that way, let's see. Yeah, so gout we understood it. Tumor lysis syndrome is described in this image, by the way. Right? Tumor lysis syndrome is something you want to make sure you get to. When you're killing cells, that always leads to more uric acid. It also leads to more phosphate, decreased calcium, and more potassium. Right? All of these things are going to have side effects that can lead to other things as well. So, of course, acute kidney injury and uric acid leading to gout is one thing that we're looking at right now related to tumor cell lysis. But you can also get seizures tetany from the low calcium because all the phosphate that's coming out is going to attach to the calcium, so you're going to run out of calcium. You'll make calcium phosphate crystals, which are actually going to get stuck in the kidney. And then, of course, with the high potassium and low calcium, you can get ECG changes, and the hyperkalemia also messes up the muscle. Myopathy occurs. So tumor cell lysis and tumor lysis syndrome in general are huge topics that you want to make sure you truly understand in an entire scope. As a method of shock studying, you can go ahead and take a look at it to get more about it. what else was I going to say? One other thing that you could do for shock studying purposes is the whole concept of what kind of kidney stones people get, right? There's many kinds of kidney stones people get, and when you have calcium phosphate or any phosphate, always remember that the word phosphate has pH written in it twice. So stones that have phosphate in it will lead to high pH. That's something that I came up with when I was revising these phosphates, revising most of these stones in general that occur, so a very, very easy topic at that point once you memorize it like that. Now, generally speaking, we looked at all of this, we got it, even here they tell you NSAID indomethacin. They write it here, but they don't write it in the final farm section, which is pretty stupid. Again, better pictures here showing you more of the tophi, that form, right? And then this image here was kind of a piss off because, of course, they didn't give you one of these three images. This far left image here is one I found on a UWorld question where you see this crystal, this needle, that isn't under polarized light. They're not using polarized light at all. You just see a bunch of neutrophils, which also help understand, and then this one needle, and you were supposed to understand that this was gout, right? So this is just normal gout. We get gout. Then you have this thing, pseudo-gout. Pseudo-gout, which is no longer called pseudo-gout, right? So now they call it calcium pyrophosphate deposition disease, but everyone's still going to call it pseudo-gout. You get pain and swelling with acute inflammation and or chronic degeneration, right? And it all presents very similar looking. The knee, however, is the most commonly affected joint, as opposed to normal gout, where the toe is the most commonly affected joint. But the knee can be affected in normal gout also. Chondrocalcinosis on X-ray, you're going to see cartilage calcification rather than the mouse bite thing that we saw. Crystals are actually going to look like this, rhomboid, and they're not positively birefringent. They're actually end up blue under parallel light rather than yellow under parallel light. All right. But the acute treatment, thankfully, is still the same. So treatment-wise, there's no difference. Right? Treatment-wise, there's no difference. You just go ahead and do the same treatment like you would for gout. This question is pretty interesting too, with, again, treatment-wise it being a problem because the answer has multiple treatments that are all viable treatments. 52-year-old woman with hypertension, DM2, comes to the physician because of a one-day history of severe pain and swelling of her left great toe. She has had similar episodes sporadically over the past 3 years. She drinks 6 beers daily, doesn't smoke, is allergic to hydrochlorothiazide and glipizide. Current medications are lisinopril and metformin. Exam shows erythema, warmth, and tenderness of the left first MTP joint and a nodule over the right elbow. The most appropriate next step in treatment is the administration of a drug that has which of the following mechanisms of action. Now, the correct answer here was reversible inhibition of prostaglandin synthesis. Acute gout is the most likely diagnosis in this patient, presenting with podagra and a tophi in the elbow. NSAIDs such as indomethacin or even ibuprofen, which reversibly inhibit prostaglandin synthesis by inhibiting both COX-1 and COX-2, are the first line in management of an acute gout flare. Other drugs that can be used in a severe flare of gout include glucocorticoids and colchicine. Xanthine oxidase inhibitors, though, can be used to prevent flares, but should not be used within the first 2 weeks of an acute flare because they can worsen the acute gout attack. And this is why it's very important to be able to differentiate the two sets of medications. Some people chose another answer choice of irreversible inhibition of COX. And you start wondering how that's different, right, from reversible inhibition of prostaglandin synthesis by inhibiting COX-1 and COX-2. So this topic of irreversible inhibition of COX, the answer is aspirin, right? Aspirin is also an NSAID that irreversibly inhibits COX, but it is avoided in gout because it inhibits uric acid secretion at low doses. And you may not have known that, right? So this is why this is a question where both answer choices look the same. Reversible inhibition of prostaglandin synthesis by inhibiting COX or irreversible inhibition of COX is the same thing. But the medication related to each of these mechanisms of action is different. You have indomethacin versus aspirin, both of which are NSAIDs, but you don't use aspirin because at low doses, it actually worsens gout. Right? So silly little things to know here and there. And even this topic from this question right now isn't actually mentioned here. Yeah, it doesn't say don't give aspirin. Right? So it's a nice little note to have for yourself. And this is why I'm using both books and stuff, because there's just too much to know and you don't really see everything in one place. Yep. So that's a good question right there to get that down. Quite a piss off of a question. Let me see if there's anything else here. No, that's a pretty obvious question. Okay, these are nice. We talked about septic arthritis yesterday. We looked at septic arthritis yesterday, which could be gonococcal polyarthralgia. That's actually going to be migratory arthritis, right? That's kind of what happens in gonococcal arthritis. So take a look at this question. This is very interesting. 27-year-old man comes to the emergency department due to severe left knee pain and swelling for the past 2 days. He has no recent injury or significant medical problems. He drinks 3 or 4 cans of beer daily, which is normal and is not alcoholic at all, but does not use tobacco or drugs. He works as a groundskeeper at a nearby golf course and has had to take some days off due to the pain. Currently, his temperature is very high, 101, not very high, but high, 101F. Blood pressure is normal, pulse is okay, and on exam, his left knee is swollen, erythematous, warm, and tender, with restricted range of motion and restricted range of active and passive motion. So that sounds like something that's infected, right? Not only does he have a high temperature, which is fever due to some infection, but the way the arthritis is presenting is also infection related. So what's the next step in management? Now you see how this is a step 1 question, but it's asking what's the next step in management. And this question, I didn't recently add it here. This has been here even when CS was still a test that was occurring. Right? This note has been here for a long time. This is an old UWorld question. So now it's becoming even more common to start seeing CK type questions in step 1 now that CS is gone. So it was a pretty easy answer choice though. Synovial fluid analysis. His symptoms are consistent with synovitis. Acute undiagnosed synovitis, especially when accompanied by fever and leukocytosis, represents a true emergency and warrants an expedited evaluation. Potential causes can be septic arthritis, crystal arthropathy, hemarthrosis, or rheumatic disease. Diagnostic arthrocentesis and synovial fluid analysis is key. Fluids should be sent for crystal analysis, cell count, gram stain, and culture. Blood cultures should be drawn if septic arthritis is suspected. And you do this before starting any prophylactic antibiotics. Right? Same thing in this question too, where the answer was antibiotics, but they had all these other answer choices that are for gout. Right? Allopurinol, colchicine, indomethacin, prednisone. 28-year-old man comes to the emergency department due to 12 hours of severe right knee pain and swelling. He has had no trauma, drinks beer on weekends but does not use tobacco or drugs. On physical exam, right knee effusion, erythema, and tenderness are present. The effusion is a sign of inflammation, but often also a sign of infection, especially when it's with erythema. Active and passive range of motion is decreased, which further confirms that it most likely is infection. Other joints are normal. Arthrocentesis is performed, and synovial fluid analysis shows a high white blood cell count. So then you know it's not a high, it's not going to be gout at that point. High white blood cell count is an infection. What would provide the best treatment for his condition? Antibiotics. He has acute monoarticular arthritis with an effusion, decreased range of motion, and a synovial fluid count, a white blood cell count of more than 100,000. And the way these other answer choices are, if this was actually a gout question, you would probably have the same answer choices, which is really annoying. That's kind of what makes these gout form questions really hard, because they all look like viable answer choices. Now you know which ones you can use for acute and chronic medication, but then even for the acute aspect, they have both. They have indomethacin and prednisone as an answer choice. And that's kind of going to happen on every gout question you ever get for treatment purposes. You have to then consider, first you have to figure out, is the person having an acute flare-up or a chronic flare-up, right? Are you giving them preventive medications, which means that they don't have gout right now? Or are you giving them a medication because they have gout right now, which is acute? If they have gout right now, then the acute medications are the chronic medications, NSAIDs, glucocorticoids, or of course, there's colchicine. All three are answer choices here. So then when you get that kind of a scenario, you need to start considering what might the patient have that would make one of these or two of these medications, that are, of the three that are viable answer choices, contraindicated in him, right? So if he has like renal problems and whatnot, then you don't want to give him an NSAID. If he has any kind of bone marrow problems, you don't want to give him colchicine, then you would just go with the prednisone. So something like that is going to happen in these questions. You have to be very careful. Last question here for joint infection for septic arthritis, because you have to be able to differentiate septic arthritis from gout. This one is a 64-year-old man, comes to the emergency department due to 2 days of progressive right knee pain. History of joint pain, but reports that this episode is more severe and is associated with right knee swelling. He says, I bumped my knee on a chair 5 days ago, and that must have started the problem. Right? This is the kind of trauma-related septic arthritis questions you're going to get. He has a history of hypertension, type 2 diabetes, chronic hep C. He takes low-dose aspirin, which is something that can predispose you to gout, right? But they're throwing that in there to really just throw you off. Everyone 64 and above takes low-dose aspirin every day, so it's not anything surprising there. One of the most commonly taken medications in the world. Metformin, lisinopril, and chlorothalidone are also on his list. He hasn't received hep C treatment yet. Arthrocentesis is performed, and the microscopic findings are shown in a histologic image depicting tons of neutrophils and one cell with a few tiny blue dots inside. So that's gonococcal, right? What is the most likely cause of symptoms? Joint infection. The dots inside the cell are bacteria, cocci. He has knee pain, effusion, and a histological image of gram-positive cocci indicative of septic arthritis. And you're done. Right? So that's kind of what happens here. This is just pretty straightforward, and the difference between, when you look at all these questions together at the same time, the difference between septic arthritis versus gout starts becoming very evident. And you start seeing that the two types of questions don't really have much overlap. Yesterday we already did the comparison of rheumatoid arthritis versus osteoarthritis, right? One of the key things were the different types of finger degenerations you can get. So you can see here in this patient, his fingers are kind of bored, bent is what I mean, and you start seeing what they refer to as an ulnar deviation, right? So here they're telling you, this is nice that they gave the normal raw picture and the x-ray. So note the typical ulnar deviation, the pinky side deviation, of the MCP joints and swelling of the MCP and PIP joints, but not the DIP, right? Rheumatoid arthritis doesn't go to the dip. We talked about this yesterday in the sense that rheumatoid arthritis is an autoimmune condition that's in your blood, and not much blood reaches the tip of your fingers, so the DIP is not involved, right? Whereas when you have osteoarthritis, you actually use your fingertips a lot, maybe for screwing things in, so the DIP is involved in osteoarthritis. That's how you memorize that. Hand x-rays show symmetric erosions and joint space narrowing involving the MCP, carpal, and radial ulnar joints. Ulnar deviation is also noted here as well. Right, so they're pointing out with the red arrow areas that have excessive whiteness or weird bends. This arrow is showing you a weird bend. Okay, so the names of these things were like the swan neck and the boutonniere, right here. Swan neck and boutonniere deformities, because that's what the fingers end up turning into. They're very strange, and it's all because the stiffness and the weird flexing of the fingers that's occurring in those patients. Right. Other than that, it's a pretty simple topic. Nothing more to really worry about here. Diagnostic criteria, you're going to need more than 6 or more points here, right? So what are these points? Well, if you have rheumatoid factor in the patient, or there's a presence of anti-citrullinated antibodies, then that's 1 point. They have signs of inflammation, ESR or CRP, that's another point. If they have inflammatory arthritis of 3 or more joints, that's actually up to 5 points right away. Symptoms duration is more than a month, 1 point. Exclusion of diseases with similar clinical presentations such as psoriatic arthritis, gout, pseudogout, or even lupus is also going to be pretty critical, so that you can rule those things out and know the differentials, right? So these points thing is not a real major issue. Of course, these are just a list of things you know you're going to see in someone with rheumatoid arthritis, right? The rheumatoid factor, by the way, be very careful. Just because someone has rheumatoid factor doesn't mean they have rheumatoid arthritis. Right, rheumatoid factor is very non-specific. Many people can have it, and it's found in many other conditions as well, so it's not a sign of rheumatoid arthritis. Right, labs, you could see anemia of chronic disease, so they're going to have high ferritin, but iron is going to look very low. Synovial fluid aspirate shows turbid fluid, low viscosity, and a high white blood cell count. X-rays are not necessary, but if you do any X-rays, then early you're going to see soft tissue swelling and demineralization. Later on, you're going to see symmetric joint space narrowing and erosions. The key thing being symmetric. See, in osteoarthritis is not symmetric, because in osteoarthritis, if you're right-handed, then everything that you did for the overuse aspect of osteoarthritis must have involved your right hand. So the majority of the osteoarthritis would also just involve the right hand. Right? That's kind of what happens in osteoarthritis. But in rheumatoid arthritis, it's an autoimmune condition that's systemic, so it's symmetric in both hands, both legs, etc. Best initial therapy for rheumatoid arthritis: NSAIDs can be decreased or discontinued following successful treatment with DMARDs. DMARDs should be started early and include methotrexate, the best initial DMARD to start with, hydroxychloroquine, and sulfasalazine. Second-line agents include TNF-alpha inhibitors, rituximab, and leflunomide. Right, but the answer you're going to be looking to pick is going to be the DMARD methotrexate. Joint deformation, osteopenia, and many other complications are related to this, as we talked about yesterday, especially the Kaplan syndrome with the pneumoconiosis, Felty syndrome with the splenomegaly. Right, these are some of the things we looked at yesterday, right on the first day, step 1. Okay, so that's your rheumatoid arthritis. Then you have your seronegative spondyloarthropathies. These are the set of your things that are related to HLA-B27, right? Chronic inflammatory disease of the spine and pelvis that leads to fusion of the affected joints, strongly associated with HLA-B27. Risk factors include male gender and a positive family history. And right here, you're seeing the thing that you might actually remember most clearly for ankylosing spondylitis, which is the bamboo spine. Right? So they tell you frontal view of the thoracolumbar spine shows the classic bamboo appearance of the spine, which results from fusion of the vertebral bodies and posterior elements. Right? Bamboo spine. It's all fused. There should be more gaps in between, and it shouldn't be so stiff looking. This person's spine is so fused that there's no space for them to bend forward and backwards. Typical onset is in the late teens and early 20s, presents with fatigue, intermittent hip pain, and lower back pain that worsens with inactivity and in the mornings. Pain is relieved by exercise, sure, because when you do exercise, you're going to try to stress this out. Decreased spine flexion is a positive Schober test, because since this is so stuck together, there's no space to bend. They have to be further apart for the spinal columns to be able to bend in certain directions, but they can't. Loss of lumbar lordosis, hip pain and stiffness, right, and decreased chest expansion are all seen as disease progresses. And this decreased chest expansion thing is a big problem you have to watch out for. This was a step 1 question. I think it's there still. Let's see. Yeah, right here, right? So here, this question. A 34-year-old man comes to the office for progressive low back pain for many years. He reports stiffness and pain, worse in the morning, but improves throughout the day, and ibuprofen gives some relief. Labs show HLA-B27 antigen. What should you monitor for disease progression? Degree of chest expansion. Right, that was one of the things you can monitor. It's usually the most accurate thing to monitor too. So you monitor degree of reduced chest wall expansion to assess disease severity. If your chest wall can't expand, you're going to have difficulty breathing, which can lead to death. The rest of these things are also seronegative spondyloarthropathies, right? Psoriatic arthritis, IBDs, which are Crohn and ulcerative, and then reactive arthritis, which is usually related to these microbes. And the patient presents with the can't see, can't pee, can't bend my knee, Reiter syndrome, right? So, a bunch of things here, but nothing that you haven't already seen in step 1, right? So all of those, all the topics we're looking at right now for CK are the same from step 1, and you can always come back here to read more about them if you forgot about them. And then, of course, you can see there's a bunch of step 1 practice questions, which will also teach you a lot because it's pretty relevant. So they list out the rest of these here, right? Reactive arthritis, psoriatic arthritis, and enteropathic spondylitis. Entero being the bowel system, right? The GIT. Best initial test is just an X-ray where you're going to see all the fusing occur. ESR, CRP, inflammation is going to be high. Of course, there's going to be HLA-B27. If they don't give you that, then it's very hard to figure out what the problem is, because this question right here of the 34-year-old man sounds a lot like rheumatoid arthritis until they tell you the HLA-B27. Right? The stiffness in the morning that improves with use is rheumatoid arthritis, whereas osteoarthritis, you feel good in the morning and then it gets worse with use, because osteoarthritis is a wear and tear disease. Right? So they need to give you the HLA-B27, or need to give you that there's negative of the other antibodies that you would find, even citrulline antibody of rheumatoid arthritis. And thankfully, treatment is generally still the same stuff. You just give them the medicine for the pain and tell them to exercise to improve posture and breathing. TNF-alpha inhibitors or sulfasalazine can be used in refractory cases, but that's usually, I've never seen that in a question. Just pick indomethacin and move on with it. Now, if the patient has, of course, as usual, contraindications to indomethacin, then you don't pick it. Then you would give the infliximab TNF-alpha inhibitor or sulfasalazine if these are possible answer choices. All right. The next topic, polymyositis versus dermatomyositis. Is this going in order here too? Yeah, right here. Okay. So polymyositis and dermatomyositis often get described in very strange ways because they can't describe it to you the same way they would describe lupus, right? Which is because you have a rash on the face, but what they often describe this as, they won't really use the shawl and face rash, but they'll just say that the person looks like they have a dirty rash or something silly like that. I don't know if it was this question. No, I don't think I have the question here. As you can see, there's a bunch of questions to practice from in the Step 1 book, so definitely make sure you go back and look at those to revise it all. These are questions of polymyositis and dermatomyositis down here, so we'll look at those right now. Let's read this first. So polymyositis, okay, first of all, they have a bunch of non-specific antibodies, ANA, elevated secretin kinase for the muscle. Then they have the specific stuff, which is the histidiol tRNA synthetase and signal recognition particle, as well as anti-Me2. These anti-Jo, anti-Me, and anti-SRP are antibodies you don't see anywhere else. So if you do see them, it's one of these two diseases, poly or dermatomyositis. Polymyositis is a progressive symmetric proximal muscle weakness characterized by endomysial inflammation with CD8 positive T cells. So the endomysium is what surrounds a single myocyte, right? Endomysium, all the way inside. And it's called polymyositis, so it's the one related to CD8, which is a bigger number than CD4. Dermatomyositis is clinically similar to polymyositis, but also involves Gottron papules, which are going to be these weird marks on the hand, photodistributed facial erythema, they call it the heliotrope edema of the eyelids, and then on the face like that, darkening and thickening of fingertips and sides resulting in irregular, dirty appearing marks, increased risk of occult malignancy, which is what this question is about, and this has perimesial inflammation, which a perimesium surrounds a fascicle of muscle fibers, and atrophy with CD4 positive T cells. Right? So the CD8 versus CD4 is a bit of a topic here. And the occult malignancy, so basically dermatomyositis is worse than the polymyositis. Right? And this question here, they tell you 42-year-old woman, it comes due to muscle weakness. Her symptoms have gotten worse since they began 3 months ago. Patient has trouble with climbing stairs and getting up from a chair. Also reports a 10-pound weight loss, subjective fevers, occasional abdominal discomfort, and over the same interval. Past medical history has GERD and hypothyroidism, for which she takes the correct medications, omeprazole and levothyroxine. Physical exam shows weakness of the shoulder and hip girdles, and an image of her hands shows Gottron papules, which they probably give a picture similar like this. Further evaluation will reveal what else, and then these were the answer choices you had. So you had to pick ovarian adenocarcinoma because there's a risk of occult malignancy. Of course, there's no relation of porphyria cutanea tarda, which would have hand lesions because of photosensitivity, but it was irrelevant. Primary biliary cirrhosis, Tropharema whipplei, or even diabetes. These were irrelevant for our purposes of this question. Right, so dermatomyositis can have occult malignancy like ovarian, lung, colorectal, or non-Hodgkin lymphoma. Right, so that's kind of what they're talking about here. Polymyositis versus dermatomyositis. They give you a nice table. They show you more pictures. Dermatomyositis is the one that's more significant and problematic. Proximal muscle weakness, though. Proximal muscle weakness, and it keeps getting worse. So now how do you help them? Well, first you need to diagnose it officially. So the most accurate diagnosis, because you can't just clinically diagnose it. I mean, sure, based on characteristic clinical and lab presentation, you could figure it out. But the best initial test is to look at the creatine kinase, which is muscle injury, and any of those antibodies, anti-Jo, anti-Me, anti-SRP. Most accurate test is to do a muscle biopsy where you would see either the CD4 and perimesial inflammation or endomysial and CD8 for polymyositis. Best initial treatment is just to give them high-dose corticosteroids and taper it off. And you probably have to keep repeating this every few months. Azathioprine and/or methotrexate can be used in steroid-resistant or intolerant cases. Right, so pretty it itself is a pretty easy topic, but it becomes difficult when they try to give you more things in the question that try to make you think into other answer choices, like one of the neuromuscular junction diseases, which also present with muscle weakness, even fibromyalgia or your polymyalgia rheumatica, all of which also present with muscle weakness, elevated CK, and some of these other things. So let's take a look at these questions right here. This first one is also related to our topic, polymyositis. A 55-year-old man comes to the office for evaluation of chronic muscle weakness. Over the past several months, he has had increasing difficulty walking upstairs and lately has noticed difficulty combing his hair and lifting objects overhead. Vitals are fine. On exam, he has symmetric proximal muscle weakness, which is exactly what we look for in polymyositis, and mild muscle tenderness but no skin rash, so it's not dermatomyositis, which is nicely named, derm, for skin rashes, right? Dermatomyositis. Muscle biopsy reveals an endomysial mononuclear infiltrate and patchy muscle fiber necrosis. So since they did the biopsy and they found endomysial infiltration, endomysium is involved with CD8 positive polymyositis. So they asked what antibody would you find? HistidotRNA synthetase or any one of the other three. All right, pretty straightforward question. And the same kind of concept goes on with the rest of these too. None of these are really that bad. You just have to know to be able to differentiate them from everything else. So we're going to keep looking at these other guys too. The differences between myasthenia and Lambert-Eaton. Is that the next topic? Let me just check. Raynaud, systemic, lupus, serum sickness, Johnson arthritis. Do they not talk about? Oh, fibromyalgia, polymyalgia rheumatica. Okay, they don't talk about it here. So we'll talk about it since we're on that page. Let me just come back to where we were. Okay, so we're here. So since we're here, let's talk about myasthenia and Lambert-Eaton as well, because these are also muscle weakness conditions and you need to know them perfectly and confidently. There's an easy way to memorize what they do in terms of pathophysiology, because I know in the beginning it was kind of confusing and difficult to remember. Myasthenia gravis is a grave problem. It's in the name gravis, right? The pathophysiology is that you have antibodies to the postsynaptic acetylcholine receptors. So you don't even have a receptor for acetylcholine. Patients present with ptosis and diplopia, which sets this aside from all the other muscle problems because of the involvement of the eyes and the little muscles of your face. You get respiratory muscle weakness, dyspnea, dysphagia, difficulty chewing, all these weird things that we're not seeing in polymyositis and dermatomyositis, right? These are just people in the other two conditions, dermato and polymyositis. Those people are having trouble climbing stairs and combing their head and stuff like that. So it's completely different. Myasthenia gravis is often associated with a patient having a thymoma, and you just treat it with acetylcholine esterase inhibitors to reverse symptoms, like pyridostigmine. So we saw in step 1 that pyridostigmine has GM here, and they wrote that pyridostigmine gets rid of myasthenia gravis, MG, right? So you don't even have acetylcholine receptors. So all the acetylcholine you're making, right, is useless because there's no receptor for it to go to. So that's why this actually worsens with muscle use. It worsens with muscle use because the more you do whatever you're trying to do, whatever muscle you're trying to use, the more likely it is that the few receptors you have are going to get occupied and overused. And then even those receptors that are there won't work anymore. So this worsens with muscle use. Okay. Compare that now to Lambert-Eaton. I wrote here, myasthenia gravis is more grave. You do not have the receptors, and it worsens with use. In Lambert-Eaton, something is eating your calcium, decreasing acetylcholine release, thus giving more acetylcholine actually helps them. Alright, so these people have antibodies to the presynaptic calcium channels, which decreases acetylcholine release. They don't even release acetylcholine, but they do have acetylcholine receptors. So if you give them acetylcholine, it helps them, right? But giving them pyridostigmine will not help them. Alright, and it actually improves with use. The more they try to use a muscle, the more they'll actually be able to release calcium, which will then in turn release acetylcholine, and it'll successfully work. Right? These people present with dry mouth, impotence, and other autonomic symptoms, which really helps set it apart from myasthenia gravis, where you do not have autonomic symptoms. Right? So there's a lot of key things. Now, Lambert-Eaton is associated with small cell lung cancer, and oftentimes what you'll see is that the question might actually start off with this. Right? A patient presents with thymoma, blah, blah, blah. What else would you expect? Maybe they have myasthenia gravis, right? Or Lambert-Eaton patient presents and then they have some kind of nodule in their lung. What do you expect? A small cell lung cancer, and then you're done. So this isn't so bad. This little story thing here really helps. I feel like it stuck to me, and I never really got confused because they're going to give you a few things in the question that'll be specific enough to help you figure it out. For myasthenia gravis, it's going to worsen with muscle use, and that's going to be pretty critical. They might even have a history of a thymoma that they already got removed. With Lambert-Eaton, it's going to improve with muscle use. Pyridostigmine is not going to help them, and they're going to have autonomic symptoms, which are very weird, right? Because it's like, how is an autonomic symptom related to myasthenic syndrome, right? So when you see the autonomic symptoms, you immediately think Lambert-Eaton, and you just let go of everything else. All right. So we'll stop here, and then in the next video we'll continue on with Raynaud phenomena. This weekend we'll be doing a lot of step 1 stuff, so I'll see you guys tomorrow morning for that.